Okay, Debbie, this is the appliance we talked about a little earlier. The reality is, you know, you have been wearing this for a couple of weeks already, but we're going to kind of pretend like I'm seating it for the first time here today. And again, for those of you, Terry, if you could take kind of a close-up of the appliance itself. For those of you who deal with orthodontics, you would recognize this looking a lot like a Hawley retainer. And the difference being that on the upper anterior, right behind the central incisors, there's a little island built up. And that little island, as you can see probably, has a little bit of white on it. And that's because when we did this originally, as I adjusted this, I had to make some adjustments and actually add a little bit on to the pink acrylic that was already there. But essentially, at the time of seating of this appliance, what we do, we take it off the model and first of all verify the actual fit of the appliance in the patient's mouth. And here, I'm going to set you back here a little bit, Debbie, okay? And again, the reality is that Debbie has been wearing this for a couple weeks, and she's going to share with us here just a little bit what her experiences have been. But just to give you the benefit or the idea of what it's like to initially seat the appliance, we're going to put the appliance in here, and they tend to fit very, very, very nicely. And the nice thing about it is that there's absolutely no interference at all with any occlusal contacts of any of the posterior teeth. And essentially what the patient is instructed to do is just to close their teeth. Go ahead and close and tap. Okay. Now again, Debbie already has gone through the process of deprogramming, but as these are initially seated, sometimes the patients will be a little awkward. They don't know where to close or what to do, and that's a very normal experience. And what we're really looking for at the time of initial seating is to have a single point of contact, with one of the lower central incisors on that little island that is built up behind the upper front teeth. And we'd like to have only one point of contact from one incisor. And we'd like, very, very, very critically, very importantly, we would like that point of contact to be a very small point of contact. And what's also very critical is that the little island, can you open a little bit for me, Debbie? That little island's built up. The point of contact, we want to allow the mandible freedom to go to the right or to the left or forward and backward. So we want that to actually be on a little bit of a flat that it does not have any kind of a cant to the right or to the left, does not cause the mandible to slide forward or to go back. We want it to really be a very solid perpendicular stop for that tooth. And we want typically to adjust the size of that island to allow maybe up to 1 millimeter of freedom to go right or left or forward and backward. And that's essentially what we have done. And as you can see here, in Debbie's case, we had to add, since it's not pink here, the white, we used a little bit of a flowable composite, which is very nice. It's very easy to add on to and modify that stop to idealize it. And what's very interesting, in fact, I think Debbie will tell you, oftentimes with even the very slightest amount of a cant or an angulation to that stop, it can take something from being very positive to very negative. It can cause, I know that the first couple of days you wore it, you were bouncing all over the place and you actually felt a little more uncomfortable. Yeah. So refining that contact, that stop, the angulation and the contour of that stop is a very, very important part of that process. So as you can see here now, what we did with Debbie, and we'll make some, oops, I'm sorry. Okay. Now just go ahead on your own, just tap, try to like tap your back teeth again. Tap, 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 tap. Open. And what we see here, excuse me 1 second, here, what we see, if I can get this out here without breaking it, you can see if you can kind of maybe zoom in on that. What you can see is a very singular point of contact, a very point. We don't want a large area of contact, certainly only one tooth. Occasionally, when one of the challenges is when the lower front teeth are very severely worn and they're very flattened out, sometimes it's very difficult to have a very small point of contact. But the idea is you want to have that point of contact on a flat area, as small as possible, and really only involving one tooth. And after achieving that, what we want to verify is, as far as the vertical dimension of the stopper, the vertical dimension of the appliance, we really want to have it so that there is no contact of the posterior teeth. And as you'll see, Debbie, go ahead and close again. You see there's no contact. And typically we like to adjust it so there's about a millimeter to 1.5 millimeters of interocclusal space between the lower teeth and the upper teeth with the appliance in. And even with that, there will be times when a patient will deprogram, and one of our instructions we'll give that patient is that if a back tooth begins to touch, we need to come back in and open up that stop a little bit, because as the condyles seat, oftentimes even with that amount of vertical opening, the posterior teeth will begin to touch again, and we have to add on to that stop, otherwise that seating process will be stopped. As we can see here, with the appliance taken out, Debbie has one single point of contact of one of her lower incisors against this little stop. As we mentioned earlier, the stop had to be built up a little bit earlier because it was vertically too close for her. And we have, again, a single point of contact, one lower incisor against that stop. And again, as you see here, it's a very nice punctuate type of point. Sometimes, occasionally, with severely worn lower front teeth, it's not possible to get a single point of contact because those front teeth are so flattened off and you have such a broad area. But that's really our objective. And again, we'd like to have, again, approximately 1 millimeter at least of space, so that at that point, if you can visualize that those lower teeth were to, or the mandible was to move, there would be freedom for it to go to the right or to the left, forward or backward, without really engaging any kind of an incline or any type of an adverse angle.